Hey guys, welcome to another episode of the Question Bank. Today we have a pretty cool case in cardiology. So, a 65-year-old female is seen in the cardiac care unit 3 days after admission. 3 days ago, the patient presented with severe chest pain radiating to the left arm, accompanied by diaphoresis and nausea. ECG showed ST elevations in leads V2, V3, and V4. Urgent percutaneous coronary intervention revealed severe obstruction in the left anterior descending artery, and a drug eluting stent was placed. Today, the patient is complaining of chest pain again in the middle of her chest that gets worse when supine and better when leaning forward. Which of the following is the most appropriate pharmacotherapy for this patient? Now, this is a pretty bulky question, and there's a lot of information, so let's dissect this question. Firstly, let's look at the age. 65-year-old female. So we know the demographic of the patient. She's in the cardiac care unit, which means her condition is pretty severe. So this is something we have to keep in mind. And she's seen today, which is 3 days after admission. Okay, so she must have had a preceding event. What is the preceding event? 3 days ago, she had severe chest pain radiating to the left arm with diaphoresis and nausea. This looks like an MI, right? An MI is a very strong possibility in this patient. So let's think about that. Alright? Now, carrying on with the question, the ECG showed ST elevations in leads V2, V3, and V4. Now, this is critical in learning in terms of which ST elevations in which leads connote to which artery being obstructed. Thankfully, this question has given us the answer, which is the left anterior descending artery. And we can also see an intervention was done where a drug-eluting stent was placed. Today, however, the patient has chest pain again. Is this an MI again? Well, let's see. Her type of chest pain is that it gets worse when she's supine, when she's lying down, and gets better when leaning forward. This is highly characteristic of a disease. Any guesses? Well, you must have guessed it right. Pericarditis. Now, there are many forms of pericarditis and many causes, but seeing that she's had an MI and it's been 3 days, let's link these together. Alright? This means that the MI, because it's in such close proximity to the onset of pericarditis, when we link all of these together, we must think of a diagnosis called Peri-Infarct Pericarditis. This would be our most likely diagnosis. Peri-infarct pericarditis usually happens within 3 to 10 days of a transmural inflammation or transmural infarction of the cardiac muscle, especially in a case where the left anterior descending artery has been obstructed. This becomes a very high possibility. Alright, so now that we've established that she has pericarditis, what is the most appropriate pharmacotherapy? Let's go through our options. So we have oral naproxen and oral colchicine. Now we know that both of these drugs are involved in the treatment of pericarditis, typically. However, UpToDate has recently released the guideline that combining an NSAID such as naproxen with colchicine is not advised at the moment, especially with NSAIDs like naproxen. Anti-inflammatory therapy may actually impair scar formation and can lead to further complications. Oral glucocorticoids are not first line. Okay? Oral glucocorticoids are not first line. They're typically second or third line treatments for pericarditis. Aspirin is an interesting one. We'll come back to that one. Intravenous glucocorticoids are never indicated for pericarditis. They're typically indicated for more severe inflammatory conditions. You can see intravenous glucocorticoids typically used for multiple sclerosis flares and things like that. It's not indicated in pericarditis. Metoprolol, a beta blocker, would be useful in certain cases of an MI, for example, to reduce blood pressure and heart rate, but in the case of pericarditis, it is not advisable. That leaves us with one option, being oral aspirin. A high dose of aspirin of roughly around 650 milligrams is typically advised. So the correct answer is use of aspirin for peri-infarct pericarditis. Hope you enjoyed it.